But I thought that it would be important to review only a bit of the history of how we got here today. I thought it would be more useful for all of us to consider where we're going in the next 35 years. Is that acceptable for folks? Okay. But to review a little bit of history. So as I said last night, 2019 is noteworthy for being the 50th anniversary of a number of events. You may recognize this scene. I got in my motorcycle and headed west on the Massachusetts Turnpike to attend this small concert in upstate New York. It started raining heavily, and I turned around and headed back to Boston. Little did I know that I could have been a part of history at Woodstock. So another important anniversary, which you'll all recognize, occurs later this month. And it's appropriate that we recognize this because, of course, the Johnson Space Center here in Houston was the nerve center for this whole operation. And this live event was viewed by 500 million people worldwide. Anyone who saw this undoubtedly remembers where you were, who you were with, and what you were drinking. But just to emphasize that there are still folks out there who believe in fake news. Anyway. So this is the list of topics I'm going to consider. Very briefly, where did Marfan syndrome arise? How medical management arose. Dr. Caselli is going to follow with surgical history. An important point I'm going to make, and I'll come back to it, is the distinction between natural history and clinical history. Natural history is what you've all experienced up till the time you started being treated, and clinical history is what you're experiencing for now and forever based on your treatment. And because clinical history has improved so much over the past decades, we're getting new insights into Marfan syndrome, and that's an important part of my discussion. So around the time that Renoir was painting in France, a French pediatrician, one of the first people identified as a cardiologist in the world, famous for a number of things, examined a young woman named Gabrielle, who he presented to the medical society in Paris. And she became known as the first person with Marfan syndrome. It was only many decades later that it became quite clear that she didn't have Marfan syndrome, but rather contractural arachnodactyly. And that's an important distinction because that's one of the related conditions that this foundation now encompasses. But it took 50 years, at least, for the basic features of Marfan syndrome to be identified. I won't go through them specifically, only to emphasize that aortic aneurysm was first realized to be an important component in 1943. So before our clinic yesterday and afterwards, we met in the Taussig auditorium in the Texas Children's Hospital. And people said, "Who's Helen Taussig?" And she was a pediatric cardiologist at Johns Hopkins. And she was a member of the team that looked at this X-ray, since there were no echocardiograms or CT scans, and said, wow, this person has an enlarged aorta. And that person had Marfan syndrome. My hero is Victor McCusick, who trained me as a geneticist, and he can be clearly ascribed the notoriety of describing the cardiovascular aspects of Marfan syndrome beginning in 1955. And he noted the importance of a leaking aortic valve, aortic dissection, and the complications thereof. And it was noted at that time that it was disorganization of the wall of the aorta that predisposed people to enlargement and aortic dissection. On your right, you see a section of a person with Marfan syndrome, and on the left is a normal aortic wall. That's not specific just for Marfan syndrome. Anyone with an enlarged aorta would also show that kind of pathology. So for many years, describing Marfan syndrome was based on the tall stature, dislocated lenses, and the cardiovascular issues. And everybody seemed comfortable with that. There was wide variation still in the people who we identified back in the 70s and 80s as having Marfan syndrome. And now in retrospect, I was mislabeling many of these people because, in fact, they don't have Marfan syndrome. They have conditions based on mutations in genes that are distinct from fibrillin 1, but we manage them the same way. And the good news is that over time, people began to respond to therapy and to live much longer. So it began, though, in 1972 with the identification of the reduced life expectancy in people with Marfan syndrome. So this is an example of natural history. This is what happens if you have Marfan syndrome and nothing is done, okay? So the two curves to the right are the life expectancy of people in the general population. The two curves to the left are the life expectancies for people with Marfan syndrome. And you can see there's a substantial reduction if nothing is done. So this was the status in the mid-1970s. But here's a list of the other interventions that were introduced over the subsequent 30-some years that show how we learned much more about Marfan syndrome and began to introduce therapies that turned out to be effective. And again, Dr. Caselli is going to discuss the surgical aspects. The bottom line shows that now that we understand the cause of Marfan syndrome and the steps between the cause and, let's say, your aortic aneurysm, we now can introduce clinical trials of medications that are designed to delay further the degeneration of the aortic wall. But this was aortic management before 1975. Another hero of medicine, the first professor of medicine at Johns Hopkins, made this statement. That was the situation back then. He also didn't know how to spell aneurysm, but and we'll go back a little further in history and look at what Shakespeare had to say. And to me, as an internal medicine and medical genetics specialist, the most desperate appliance I could think of was to refer a patient to a surgeon. And I actually stood in on any number of operations on my people with Marfan syndrome. But at the outset of surgery, mortality was extremely high. And most surgery was done only when a person was near death. And it was the gentleman in the right-hand side, Hugh Bentall, who introduced a surgical technique we now call the Bentall procedure that revolutionized surgery on the aneurysm in people with Marfan syndrome. And to the left of your screen, you see one of my heroes, Vincent Gott, who was chief of cardiothoracic surgery at Johns Hopkins. And he and I collaborated for a couple decades on determining the best time to intervene in folks before they developed an aortic dissection. And there were other surgeons doing this operation as well, but we had a very large series through the 1980s that led to acceptance of prophylactic, that is preventative surgery to keep people alive. Here were the indications as surgeons got better and more confident. The diameter at which we would intervene to prevent dissection became lower, and that helped prevent people from suffering a sudden dissection. So there was an international meeting on the 100th anniversary of Marfan, not describing Marfan syndrome, and the gentleman seated in the middle is Hugh Bentall, a surgeon from London who described that surgical technique. And surrounding him are patients who were at that meeting, none of whom would have been alive without that surgery. And on the lower right-hand side, you see Cheryl Gassner. So, what was the result? The left-hand curve for females and males showed the data that I described earlier, and 20 years ago, 25 years ago now, you can see that the life expectancy had increased pretty dramatically. Today it's even better, although we don't have the data at hand to prove that, but it's quite clear that you're living much longer because we understand the natural history of the aortic enlargement and can advise when to intervene before any problems arise. So prognosis, that is what the future holds. I said I'd come back to this. Natural history is what happens to any particular organ system if nothing is done. Whereas clinical history is what happens when you do intervene, even if it turns out not to be so good. Nonetheless, that's defining clinical history. So the remainder of my comments will make a distinction here because natural history is age dependent. As you are all aware, many of the features of Marfan syndrome develop over time. And if the natural history is to be examined further, then you need good clinical history to keep you alive long enough to see what's going to happen in the future, because you're living longer. And I want to describe the features of Marfan syndrome other than the tall stature, the dislocated lenses, and the aortic aneurysms. And so I think we're all committed to studying formally what the new natural history is of Marfan syndrome. And there's no doubt that new problems are going to occur because you're living longer. And I want to just briefly talk about some of the organ systems that are involved and how they interact. So if you have severe lung problems, that can actually influence what the cardiac problems you will develop later in life. So we know about abnormal pulmonary function tests. Dr. Neptune talked with those of you who were worried about this yesterday in clinic. And there may be some importance in doing pulmonary function tests, but to interpret them properly, not having them read based on your actual height, because that then will tell the lung specialist that in fact you have reduced lung volumes when in fact you don't. So we now measure pulmonary function based on what your height is when you're sitting on the floor. Pulmonary function can be affected by anterior chest deformity, a pectus, or severe scoliosis, and that needs to be taken into account for the future as well. We continue to follow the skeleton to see if there in fact is abnormal weakening of the bones, osteoporosis. Some patients calling again. And the question is there an increased risk of fracture going forward? Also, the joints tend to deteriorate faster and worse in people with Marfan syndrome. And that raises the question, is joint replacement as good for you as it has been for me? I have a fair amount of titanium in my legs. A neurologic aspect is due to dural ectasia. That's a term that, unfortunately, some of you are accustomed to. We also know that cysts in the liver and the kidneys can occur, and that there are problems with sleep. So this is the dural ectasia. The rod is in a young woman who had had spinal surgery, but at the base of the picture you see a collection of dye that shouldn't be there. It's a myelogram, a test we don't do anymore. But that showed that there was a widening of the sac at the base of the spine. The top picture shows a normal CAT scan through the pelvis. And you see that there is really very little in the way of enlargement here, where the nerve roots are going out to the pelvis and to the legs and to the bladder and so forth. Whereas this is the same cut through the pelvis in a person with Marfan syndrome, and you see how dramatically enlarged these sacs are. And so right around your tailbone, we're likely to see you complaining of a pain in the And so this is an issue for which we don't have very good treatment, and yet many of you have it or will develop it. So here I mentioned cysts in the liver and in the kidney, which initially people thought, wow, those are going to be a big problem. But in fact, now that we've followed the natural history of them, we know that they are quite benign and almost never cause any problems. Sleep. Many of you aren't aware of issues. It's usually the person with whom you're sleeping who points this out based on your snoring. But it's very common. And so the airway narrows because it's unusually flexible, and when you lie on your back, it tends to close off, which produces the snoring. But snoring is really not the most important aspect of sleep apnea. It can affect the heart in a fairly severe way. So here's just a list of the various problems that are emerging in the 5th, 6th, 7th, 8th decades of people with Marfan syndrome. There's an increased risk of cataracts occurring earlier, and you know about the risk of retinal detachment. Other cardiovascular features, other than the aorta or the mitral valve, can progress. And one of the important things we need to keep track of is whether the heart muscle weakens over time, independent of any severe other aortic or mitral valve problems. A dissection beyond the level of the aortic graft can occur, and we need to understand better how to prevent that. We did a study trying to figure out when, during the year or during the day, people with Marfan syndrome dissected. And in fact, it's in the winter months and early in the morning. We call that chronobiology. It turns out that's no different than people in the general population who dissect who don't have Marfan syndrome. But you may want to move to a warmer climate and stay in bed longer. So these are the blood vessels that go to the neck, and you see that the middle two are quite kinked, tortuous we call it. This is a phenotypic characteristic that Shane Morris and Ron Lacrow described. We don't really understand what this holds for the future in these arteries separate from the aorta. Here's an example of heart muscle that is weakened because that chamber is about 50% bigger than it should be. People always ask about pregnancy, and we would typically recommend it if the aortic diameter was above 40 millimeters. Things have changed, and now some women will have preventive surgery before they become pregnant, and that seems to be doing very well. Some women do dissect, and that's usually after they deliver, and we're wondering whether that is more frequent in women who breastfeed. So we're cautious in how we encourage women to breastfeed, and there are potential biological reasons for that. We also know the reproductive risk of 50-50 if you have Marfan syndrome of passing it on. There are a number of options: prenatal diagnosis, in vitro fertilization, having a surrogate mother. And you probably read in the news about this physician in China who has actually done gene therapy in, not based on Marfan syndrome, of course, but in another gene. And boy, he has certainly not been accepted for his work, and we're not nearly at the point of being able to do this for Marfan syndrome. But anyway, if you're thinking of reproducing, be sure to discuss this with your physicians. So skeletal muscle, you tend to become a little weaker with time. As you're growing up, you tend to be very tall and thin. But as you get older, there is a marked tendency to put on fat around your belly. And this is due to a particular type of fat that's accumulated. And again, we think there's a biological reason that this accumulates in folks with Marfan syndrome. But psychological issues, undoubtedly a number of you are concerned about this, but psychiatric features, conditions are not increased. But certainly there are increased concerns about what your underlying health involves and what the future holds. And that's one of the reasons that we're trying to learn what the natural history is going forward. But don't ignore your other health issues just because you're so focused on Marfan syndrome. I'd like to think of this as a Damocles syndrome. You're familiar with Damocles, who would have a sword hanging above the head of guests he invited to dinner. Then to make a point, he would say, and so I think that people with Marfan syndrome are always concerned, what's the next thing to happen to me, right? And if that's a major aspect of how you view life, please seek some counseling for that. We've also explored quality of life, and most people say, yeah, my life isn't as good as it could be if I didn't have Marfan syndrome. It's due to many of the medical issues, the increased psychological concerns, physical fatigue. But then there are aspects of life that really do improve quality. For example, having health insurance and being employed. So these are important aspects. So what's the future? We need to study both of these aspects. We need to do clinical studies on rare disorders. Here's just a list of issues I've talked about. Here are some other issues I didn't have time to talk about since I'm being told to get off the stage. And you may recognize some of these concerns that you yourself have and that we hope to study in the future. So what are the prospects that you'll grow old? Actually, I prefer to say mature. If you have Marfan syndrome, I think there are actually today very good. What are the prospects of staying healthy, which is a separate question, and I think they're pretty good. But it's going to take work on all our behalfs. So our desired management outcome for folks with Marfan syndrome is illustrated here. But don't ignore the fact that the longer you spend here, the more important the years you have left are. So here are some of my collaborators over the years to whom I owe a great deal. So thank you for your attention.